This is a Defocus Media production. What's up, everyone? It's your favorite optometrist, Dr. Daryl Glover.
And I'm Dr. Jennifer Lyerly, resident optometry nerd.
And welcome to Defocus Media, optometry's #1 podcast, where we discuss the hottest topics, latest technology, eyewear, practice management, and more. So sit back, relax, and defocus.
Hey everybody, I'm Dr. Jennifer Lyerly, and welcome to a new episode coming at you live of the Defocus Media podcast. We've got a really exciting topic tonight because we're talking about kids. And when I first started in optometry, it was probably the thing that I was least likely to pursue as far as a specialty in practice. I think a lot of us leave school thinking we want to do disease, we're going to do ocular disease management. And then you go out into the world, start seeing patients, and you realize how much children need our help, how influential you can be in impacting their performance in school and just their lifelong health and vision. And many of us, as we go through time, realize, oh my gosh, this is a totally underserved population that's starving for our attention and care and eye care. And we start thinking about building that into a core part of our practice. Now, many of us are doing it at an exceptionally high level and have things that they can do to share with others of us who want to improve that. And so we have two leading experts in the field of pediatric optometry with us tonight. Before we get into introductions, I did also want to say thank you to Cooper Vision for very generously sponsoring this discussion. We love Defocus Media and the podcast that we're able to bring to you guys, but it always helps to have some support behind the scenes too. So thank you, Cooper Vision, for helping us make this episode happen. All right. Well, I mean, you need no introduction, but I think I should offer the floor to the gentleman to my right side, Dr. Nathan Bonilla-Warford. You really are a leading innovator, I think, in pediatric eye care. When we think of pediatric optometry, your name always comes up first. So would you mind sharing a little bit about your practice with us?
Sure. I'm very glad to be here. I'm looking forward to a wonderful conversation. So, it's kind of funny because you mentioned, in school about children. I didn't have children at the time. I hadn't had a lot of interaction with children. I didn't have any idea that I was going to go into this specialty, at all. It wasn't until kind of the end of third year that I kind of fell in love with the vision therapy side of it. And then that just everything sort of fell into place, after that. So I graduated from ICO in 2004, did my pediatric residency in 2005, opened my practice in 2006. It started off less than 900 square feet, one exam room, and, like 4 staff members. And we moved to a bigger place, and then we moved to a bigger place, and then we established a satellite practice, which is called, my main office is called Bright Eyes Family Vision Care. My satellite is Bright Eyes Kids. And that's where I am right now. And you can see the Lego behind me, and we've got toys, kind of all over. And it is exclusively for, for kids. Sometimes we'll see adults who have binocular vision problems, but all the waiting furniture, half of it is like children's size, and, everything is designed to make it easy and comfortable for kids. So this really allows me to provide pediatric primary care and vision therapy and myopia control all day, every day.
Well, our other expert guest is doing things in a very different realm, which is why I love bringing you guys together, because you're showing two very different sides of pediatric optometry. Dr. Yos Priestly is in an OD-MD practice in Durham, North Carolina. And did you similarly kind of stumble upon pediatric care as you went through school, or did you always kind of know this was a passion for you?
So I always knew I wanted to do something pediatric related, and I bounced around between going to med school, being a kindergarten teacher, and I landed in optometry school knowing that I wanted to pursue pediatrics. So from my first semester there, I started tracking down the peds faculty and knocking on their doors and just hanging out with them and seeing what opportunities I had. So from day one, I was charting that course towards doing peds. And then When I graduated NECO in 2010, I stayed on there and did my pediatric residency there, which, if you're not familiar, you kind of rotate to lots of different clinics in the city, and you get all these different hospital-based experiences and clinical experiences. So it was just all kinds of peds all day, every day, which was I was living my dream, because I don't want the adults and the dry eye and the oct disease, the adult oct disease. I love the pediatric oct disease, but the adult oct disease can stay over there. So I was thrilled and loved it. And then I moved down to North Carolina, and I worked in a private practice for a couple of years where I sort of did 50-50 adult care and pediatric care, including vision therapy, which was great because I actually didn't do a lot of VT when I was in my residency. So I learned a little bit about that. And then I landed in a hospital-based clinic. So that's where I've been. And that's been really great because I can do a lot of specialized pediatric care. So I do specialty contact lenses, myopia control. I do lots of strabismus and amblyopia care, and I also do peds low vision. So I have all these little niches that I'm sort of filling these needs for these very high need kids. So they have a lot going on, and we don't have a lot of providers who can do peds low vision or fit a scleral lens on a 3-year-old or something like that. And I love it. So it works out nicely, and I get to do that every day. So it's been awesome.
Well, you mentioned pediatric residency. I obviously know, Dr. Priestly, you did it. How essential do you feel like this is for anyone interested in pursuing a specialty in pediatric vision care?
Yeah, I mean, there's always different, roads to where you want to end up, and not everybody takes a direct route. But for me personally, it was the best year of of my career. Probably, I got to hang out with people that were great teachers and mentors, and taught me so much, and I learned so much and had so many experiences. But then also gave me opportunity, because I can't learn everything in one residency year. I mean, you can feel more confident and feel prepared to go out, but you still need that phone a friend, so having those connections and, knowing who to reach out to if you have a question about research, or you have a question about myopia management, or you have a question about low vision, peds low vision, then you have all these connections, and it's been amazing. I still reach out to them now to mentor me. So I think it was awesome. I don't see how I could have gotten where I am now without that, but I know there's other routes here. So there are a lot of people who may not have started off that way, but I still think about, I wish I could go back and do it again, because I could probably still learn some more from all those awesome advisors. So I highly recommend it. I had a great experience.
Dr. Nee, what about yourself? Did you pursue a residency or?
I did my residency in Chicago, where my wife and I were living at the time. And I almost entirely agree with Dr. Priestly. I would not go back and do it again because I'm almost 50 now, and I've discovered that naps are great. And
I don't know what that is.
I didn't do a lot of sleeping when I was a resident. I would find that to be pretty challenging now, but in every other way, I agree. I knew that I was going to do a residency from the get-go, because I was considering going into full, academia, like applying, to be a professor, or moving to whichever state would have me, and just that was a definite possibility for me. I didn't do that, but so I knew I was going to do a residency. And when I was talking to people as a fourth year, a lot of times I heard something similar to, for the given specialty you're interested in, 1 year of residency is about 5 years of intense clinical experience, because it's just case after case after case after case. It's not, they sort of trickle in, that's you're the person that they send those cases to. So in that respect, it is incredible experience. Absolutely, you can get that experience in your own clinic, or outside of a residency, but it's faster. What Dr. Priestly also said, which I want to echo completely, is one of the things residency taught me was how to interact with other specialists outside of optometry. And not to say that you don't learn that in optometry school, but you don't learn it to the degree that you do. And in some degree, I'm I'm kind of envious of her because, it takes a lot of effort for me to reach out and build relationships with other doctors, strabismus surgeons, like low vision specialists who are willing to see kids, retina specialists who are willing to see kids. I mean, those don't just happen. They don't come to me on their own. So it takes a lot of work on my part because I want to provide that care by referring them to the appropriate people. And so it's great that you're able to. But having the residency made it a lot easier for me to pick up the phone and reach out to those people. And not to say that you can't learn it otherwise, but it made a big difference for me.
Well, with Dr. Priestly, you're in such a unique setting where you, being an OD/MD hospital-based practice, the patients are almost high need, but coming to you because it's within the system. Where Dr. Bonilla-Warford, you kind of had to build a practice and say, hey, we take care of kids here, and it's not intrinsic for that to happen. So I'd love to, you've got your Legos on the back wall. You talked about the waiting room with kid-sized furniture. Any tips that you have for, trying to set a flag to say, we see kids here, please come, when you don't have that backbone of a setting that's internally referring it?
So there's a lot of different things that we did, some of which have worked really well, some of which, have not worked really well. I was lucky or smart, depending on how you want to say it, that we were very proactive very early on when social media marketing became a thing, and so that really helped, using Facebook and Twitter kind of early on to sort of reach out to moms groups. And, very frequently parents will tell me like, oh, I asked my mom's group on Facebook and they all said, bring my kid, here. And so, having that presence has been really, really helpful. A couple other things that have been, you can't overlook how critical, I think, for us building the second office and branding it separately. So there's like Gap and Gap Kids. When I go to a pediatrician's office or when I go to an ophthalmology, clinic, and I kind of present my, my card, or I'm talking to somebody, I think that there's a big difference in appearance or perception. I can either say, I'm an optometrist who sees kids at Bright Eyes Family Vision Care, or I own a pediatric optometry office, and so that sort of is a big signal to both parents and providers that, we're taking this, very seriously. And I want to say one more thing. There's a million things I could say, but there are so many extremely highly skilled optometrists who are at settings that just don't see kids or don't do as much with kids as the doctors could. So making sure that we're constantly reaching out to them via letters, via office visits, et cetera, so that they know and can feel comfortable sending patients to us is really critical. I mean, we never stop doing that.
I love the branding aspect of what you do, because you guys, you have the separate office name. It has its own website. I'm sure it has its own social media handle and page. So it's got a true identity separate above and beyond the practice. And many doctors wouldn't think to do that as a separate entity because that's twice the work. That's twice the brands and identity to manage. But it's definitely had a big payback for you by putting that investment into it. Let's talk about, because you guys mentioned, obviously, when you do pediatric care, there is a ton of different ranges on that spectrum, from routine vision care to low vision. You talked about specialty contact lenses, Dr. Priestly. Obviously, vision therapy is a big part of this. But myopia management is another very big part that I think has really finally gotten a chance to take off as we've gotten FDA-approved treatments. Talk a little bit about how you've incorporated myopia management into your practices. Dr. Priestly, if you want to go first.
Sure. Yeah. So I think it was a little bit slower going in a hospital setting versus maybe a private practice setting to move the needle and shift perspective on it. Fortunately, we've had like full support of the MDs in our clinic and everybody, I think, because we have these FDA approved treatment methods and we have all this evidence-based medicine now that supports it. So it sort of trickled in over the past several years that has really like taken off over the last year or so. So we initially sort of incorporated it into our day-to-day clinic, but we have a really high volume, fast-paced clinic, and it's just not conducive to the conversations and the chair time needed when you're discussing myopia management with patients. Mm-hmm. So we've actually now over the past year sort of created within our pediatric clinic a myopia management clinic. So we have longer slots and we can give patients more chair time, make it hopefully, a more streamlined and efficient visit. We're getting there. So that's been really great. It's really taken off. And we've fortunately had a lot of support from our PR team and our marketing team and our, clinic coordinators and everybody. And when we're in a hospital-based clinic, it really takes all hands on deck to make something happen. And it was a little slower than maybe we would have hoped, but it's now up and running and we're really excited about it. And I feel fortunate that I work with pediatric ophthalmologists who recognize myopia management as an area of need and an important area that's really becoming like standard of care for children. Mm-hmm. So we're excited about it at our practice. So it's been good.
Did you think because of that MD aspect of the community, it took the MiSight approval to be able to ever brand a myopia management clinic?
I think it certainly helped to kind of make it where we have more options to provide to patients. I think they sort of understood that it's not just like write a script for atropine and like see you next year. So it's really a whole process now of monitoring axial lengths. Like we're understanding what goes into managing these kids with myopia. And I was just talking to one of them this week about preventing myopia onset, which I think is just like awesome that we have MDs that are supporting that and thinking about these younger kids and how we can help them too. So yeah, I think they're so excited about MiSights when we talk about them. They're like, what is this lens? So it's been really great. Yeah. So they love that. And it's been exciting to have lots of different treatment options to offer to parents. And it's great when we're going through the education about it that we can give them FDA approved things. I used to just prescribe off-label contact lenses, but now I can point them towards like specific research and tell them this is, a treatment lens and things like that. So it's been helpful as part of our patient ed and helping families decide what's best for them because it's not one size fits all. So it's nice to have lots of different, tools in your toolbox.
Dr. Nate, when did myopia management become a core part of what you were doing with Bright Eyes Kids?
We started about a dozen years ago, but at the time, it was, a very tiny part of the practice. Months would go by before I would have a new patient start, or there would be a new piece of research, or anything that was like kind of real critical, and then slowly the pieces kind of came together, and I definitely agree that sort of the clincher was the MiSight FDA approval, and now literally every single day I'm doing myopia management on some level. And, and especially, at Academy, this year, you have to respect and appreciate the degree of thought and effort that's been put into the research, the clinical data that Cooper Vision has on that lens is kind of mind-blowing. It's an amazing amount of data, and it's very persuasive, and it's very cool. So I started with Ortho-K because that's sort of what people were mostly doing then.
Yeah.
Then I added atropine kind of reluctantly, and then I added off-label contact lenses. But now I want to say one more thing is I have noticed it's been hard because of the pandemic. So it's not like I'm doing what we used to do, which is set up kind of a lunch and learn at either a pediatrician or an ophthalmology office where we go in and, we're lucky if we get 5 minutes with the actual doctor, but then we get a lot of time with the staff. And, we haven't done any of that in, 2 years. But I want to resume that because I know that there are pediatric ophthalmologists in my area who are embracing myopia management, which I never would have thought 5 years ago. Not even 3 years ago would I have thought that. So the tide has absolutely turned in that respect. And I think we're closer to it becoming just normalized and mainstream.
Well, in building out this specific aspect of your pediatric practice, any missteps or things that you feel like were challenges that you feel like other doctors could learn from?
I would say we sort of did myopia management we've done it for several years, sort of like Dr. Bonilla-Warford was saying, like in sort of drips. So there were just some patients and then it sort of started ramping up and we started doing more testing, axial lengths, more visits, but we didn't really have a way to bill it. And we didn't have the infrastructure in place to put patients into a program. So there was this sort of awkward gap of patients who were seeing sort of no charge visits and not, in a hospital-based clinic, sometimes I build things I don't know what's actually coming back to me. But now that we have a program in place, it is kind of this like awkward transition period of trying to get those patients into the program, or maybe they're never going to get onto the program. And there's always going to be this group of sort of grandfathered in patients. So I would say, like, if you're thinking about myopia management, try to get all of your ducks in a row, get your program set up, do your research, think about what treatment methods you want to implement, and then go for it full on, because sort of doing it halfway was sort of awkward for a while. So it's much better to have a whole system in place before you like hit the go button. So
I love that's perfect advice, especially with the atropine, because there was definitely a time where we're just like, oh, atropine, you're like, yeah, let's get you on the atropine. And then those patients have been on atropine for like 6 or 7 years. So am I enrolling them in the atropine program now? So
right.
Yes,
Exactly.
I understand that.
Yeah, it's hard. It's hard to make that transition. So yeah, I don't know. I think they'll probably be 20 years old and I'll be graduating them to adult clinic and I'll be like,
yeah.
you can finally have everyone in my program.
What about yourself, Dr. Bonilla-Warford?
I can think of a handful of things for sure. And this goes, I think, very, very closely along what Dr. Priestly was saying, and that is, it took a long time before and I don't know why I didn't think about this earlier. In retrospect, it's super obvious, but we've had like a vision therapy kind of global program for a long time, and that's been very successful and natural, and it works really well, and we're really happy with it. But for years, we sort of did myopia management kind of piecemeal, and it wasn't really until I got bit by poor compliance that I really learned, this isn't going to work, and the patients aren't going to have the results we want if we don't have like a unified program. They buy in from the beginning, and then they know that they're going to have follow-ups. We're going to be doing testing, axial length, etc. Periodic, psychophalangic refractions, etc. And so I can't emphasize that enough. And I think that that's exactly what Dr. Priestly was saying, maybe in a slightly different angle on that topic. But you're not going to be as successful if you haven't sort of thought the whole thing out. And then the corollary to that is, no matter how smart you are and no matter how organized you are, if your staff isn't fully trained, it's going to fall apart somewhere. I mean, you just have to have the entire staff on board from the first phone call to, you know, to every visit and every person they interact with. We have a myopia control coordinator who's like a designated staff person specifically to kind of do the big overview. But every single person who touches the phone and every single person who interacts with patients, you know, has to understand why. I have a little like course that it's a shrunken down version of a lecture that I give to professionals, but I give it to every new staff member when they come in. And so I think that's just we depend on our staff, and they're smart, but they have to be given the tools to be able to represent us well.
So true about that one. Like you said, you have to empower them to know what's going on, because it is very confusing when we think about, because my practice also very much like you guys, we're doing a global period. We found that to be the most successful. But then you'll sometimes get into these awkward situations where, oh, now it's time for the annual exam. And like at that last visit of the global period, when you know the annual exam is coming up, you got to make sure you communicate with your staff in front of the patient. Like, we need to make sure we're pulling any vision insurance benefits for the next visit. And this next visit will not, you will have your XX copay. But I mean, sometimes if you're not the one directing that, maybe the patient's always been cash paid. You never even collected insurance from them because they paid cash for their global period. And then now suddenly they're here for the annual exam and they're like, oh, I thought this was one of our no charge visits. And I was like, oh, this was our exam today. All right. So these kind of like mundane things can really clog things up and make it look extremely unprofessional to the patient where you weren't prepared for them. But you've got to empower your staff to get them on the right page to know to ask those questions. Let's talk a little bit about communicating with parents, because I've personally found the biggest challenge to this is helping parents understand why they need to strongly consider enrolling their children in this. Many parents of these myopic children are myopes themselves. This was never something they were offered. It seems like it's coming out of nowhere to them because no one in their lives has ever done this or talked to them about this. And it can be an uphill battle to get a parent on board with this concept. So I want to hear from experts that are making this happen at a very high successful rate so I can learn what I'm doing wrong. What have you found to be some of the keys?
I think something that's been helpful for us was putting together patient ed materials. So I spent a long time writing up just information about myopia and myopia progression, myopia management options, and it outlines a lot of things. We have a patient population that's really interested in where are the actual studies. So I kind of found places they could access full text articles if they wanted to read more about it. And the pediatric ophthalmologists have access to my patient ed materials. So they're giving them that material from day one. And it's a discussion that's starting really early. So it's starting sometimes before they're myopic. It's starting sometimes with their first glasses prescription and then going from there. I'm honestly finding more and more parents who are coming and asking me about it. So I don't feel like I have to do a lot of convincing lately. I'm just presenting to them just like you would present options for dry eye or for glaucoma treatments or whatever. These are your treatment options. We can do glasses, and this is the expected progression over the next 10 years. We can do these other treatment methods. These are in research shown to reduce the progression by X amount, X amount, X amount. So by giving them the data and the options and allowing them to make a decision with me as to what they think will be the best for them and their child, it's gone, we've had a lot of interest in a lot of patients opting to do it, or we open the door and we just get the ball rolling and they can think about it and, enroll later on, right? I think that's what we saw in the newer MySight study that just came out, was that even the older kids benefited from treatment. So there's not a window where everything is shut. We can start talking about it when they're 6 or 7 or 8, but they may not choose to enroll till they're 9 or 10. And that's okay for some families. I don't think we're there yet that every single kid has to do it, but I think it's something we have to discuss and let them know as an option. So I give them printed material. We have the sort of basic discussion, and they have information of how to get to our myopia clinic if they want to have a more extended discussion about it. So we're just trying to give them as much information as possible, access to information, and helping them decide what's going to be best for them. But having all the research to back up what I'm telling them has been really helpful, because a lot of families appreciate that. So they're looking to us to help guide them. So I think it's been helpful to have that information. So
I agree with all of that. I would say one of the things, I mean, I guess I've done it different ways. And I've made some mistakes, along the way. I've learned that being too excited about it is not helpful. Even though like I'm excited about the data and the opportunities, and I think it's absolutely the best thing for them. Um, and I also think I didn't really ever do this, but I've heard other lecturers, I've heard other schools of thought out there that you have to sort of put the fear into them, and that is not my style at all. I have adopted a very almost sort of just matter of fact aspect of it. Like, your child, has myopia. We see this a lot, especially now, and we always have to treat this as a short-term and long-term problem. In the short term, they need to be able to see the board at school and play sports and do the things they want to do. Long term, we need to keep the prescription as low as possible and their eyes as healthy as possible. And then I get into the axial length, component of it. I find some people say that the axial length discussion is too wonky or too detailed for parents, but I don't think it is. I think they love it. As a matter of fact, I have a really simple education sheet, which just I don't have it in front of me, but it's just got like a sort of a normal sized eye, and then it's got like a eye that's sort of stretched out, and I just write on it, this is what's normal for their age, this is where they're at, this is the difference, this is what we want to keep them under, this is how we can do it. And then and generally they just I let them ask questions, and then it goes from there, and it's pretty successful. I would say by far the easiest conversations are when they're referred from other specialists because and that happens really regularly now. I mean, so much so that the staff doesn't have to come to me like, oh, how do we handle this situation? Because we have a protocol for it and they know how to do it, and they just show up on the schedule, and it's like, okay, this is how this is how this is gonna work. So the other thing I like to do, and I really I like viscerally oppose anything that's like cheesy or smarmy. Like I can't handle it at all. But I genuinely mention that both my children are in myopia control programs, and they, by that point, we've already developed like kind of a rapport because I've talked to them, I've seen them maybe more than once, etc. And so and there's pictures obviously of my kids around, and so I think that sort of reassures them that I really believe in this.
Yeah.
And so but again, I don't like hold that out there as like a salesy thing, but I do, it's just like I said, it's just a matter of fact thing. If this was my child, this is what I would do because that's what I did.
I love that. I think it just kind of connects with, this is what I would do for the people I care about in my life. So of course, this is what I'm recommending for you. And I can't agree more with the fear discussion, where that does often come up, where if you have a parent who's kind of pushing back on why should I care? Why should we, we'll just get LASIK when they're adult, talking about retinal attachment, glaucoma. These are numbers and stats that feel like they should be very motivational, but I've definitely had that backfire in the exam room where kids starts crying uncontrollably, and then parents are upset that I've scared the child, and we did not do myopia control. So you have to, there's definitely psychology where there's lines with fear that you don't want to enter into the conversation. It needs to be more positive. And I love the way that you guys are doing that, especially with a simple drawing. That's not scary. So let's talk about, because I think all of us, one of the ways to have this conversation is approaching kind of a holistic well-being of the child. So many parents ask us about setting limits on their child's screen time, right? It's a conversation that every parent, I feel like, brings up to me about, tell them how many times they should be off their screen, or like what supplements should they be taking for their eyes. I get asked that a lot. And so how do you incorporate kind of a holistic approach to myopia management in your discussion with parents?
Yeah, I mean, it's just part of our discussion from the beginning, really. I mean, that's the first discussion I have with parents, every parent of a child who's myopic or looking to be myopic, or a parent who's myopic and their child is not. And so talking about that, about screen time recommendations, near work recommendations, visual hygiene, outdoor time is a really important one that we talk about. So we try to hit on all those things from the get-go, because we're not just going to be treating, with these clinical interventions. It's like the whole picture of what is your child doing every day. And I try not to get into the nitty-gritty of it, but like there's genetic components and there's behavioral components, and we can't control the genetics, but we can control what you're doing and your behavior. And if we're going to trigger these on switches to these genes and things like that. So that's just part of our discussion with every child. And fortunately, like our whole clinic is on the same page with that. So all of our ODs and our MDs are having the same discussion with the kids. And I think, again, it kind of circles back to getting all that patient ed together for our patients, but also for our colleagues. So everyone's on the same page from the start. So we all start that conversation really early. And I think parents really appreciate that. I mean, I think it's such a paradigm shift from like when I was myopic and I got my first glasses and it was like, here's your glasses, see you next year, right? Like to give people something they can do and have a little bit of control over it is really empowering. Like I tell them their child needs glasses and it's like, oh, such like this heavy moment. And then it's like, but here's what you can do. Like we can keep that screen pushed away. We can set limits. We can, get outside for a couple hours each day. And then they like feel a lot better because there's something they can do. So I think that's been really a positive part. And I appreciate all the people working on the research that helps me be able to give that information to my patients, because it's been a game changer. Even from like 3 or 4 years ago, the conversations I'm having now are very different. So
I absolutely love that. I've never thought of phrasing it that way, but I'm definitely going to utilize that in clinic now, where it's like, oh, you do need glasses, but let's empower you on what you can do to prevent this from getting worse. Because there's been this very large misperception that I think many of my patients have, where like, oh, you prescribe them glasses, that makes them worse the next year. We need to kind of turn that conversation around. We're like, oh, no, we're empowering you with all the tools to keep that from happening. These are the XXXX things that we can do to help that. And then obviously my myopia management treatments add into that as additional options to keep that from getting worse. Any discussions that happen in your exam room, Dr. Bonilla-Warford?
So, I think this happens on kind of 2 different levels. Pretty much every single patient that comes in gets some version of kind of what I think of as sort of the common sense, things like, kids need to, get enough sleep, and they need to have a good diet. And I'm not a dietitian and I'm not a sleep specialist, but I mention that those things are like interrelated to, proper visual function. And, I definitely talk about, device time and outdoor time, all the time. And, I mean, there's no limit to the ways that the pandemic has sucked. But one of the ways that it sucked is that, and I don't know what you guys have seen, but my impression is parents are so much better now than they were maybe 5 or 7 years ago about setting limits for their kids, because they just didn't really know, and they kind of thought it was cute that their kids could use devices because it was all sort of newer technology. And so parents really didn't know, and then they started to have a little apprehensive feeling about it, but they wouldn't really know what to do, so they would sort of ask. And then parents got much more sophisticated, at least the ones in my my area, and they sort of learned about sort of like limits, and they sort of learned about how to use parental controls and all of that stuff. And then we had the pandemic, when all rules went out the window, and all of a sudden education and social and entertainment is all on screens. So we took a giant step backwards, and I honestly don't know if we're ever going to recover from that in terms of visual visual hygiene and, ergonomics, and all those things. So that conversation, I mean, you can ask my scribe and my staff. I mean, that conversation never ends. I mean, it's like all day, every day. That's just one of the, it's probably like, cover your mouth, when you sneeze, like the conversation that people have at pediatrician's office. I mean, it's like, we talk about that all day. For the people who enter into our myopia control program, we do not do vision therapy with them unless if they have an identifiable binocular vision problem that we're trying to solve. But we do have them do a single session of what we call our visual education program. And it's not necessarily meant to have myopia control effects, but it's like a little tiny, fast food version of vision therapy, where we teach them about ergonomics and we teach them about harm and distance, and we give them a clear, transparent bullseye so that they can learn that they do have voluntarily controllable accommodation, because people don't know that. It's never really occurred to them, and so we, it's about a half an hour, and the patients are usually interested in it. The parents are like fascinated by it, and usually there's siblings that are sort of along, and that's the type of thing that I would love to do for every single patient, because I think it's so important, but it's not really practical to do with every single patient, especially if they're not really asking for that level of information, because they're busy. But that's extremely well received. And the fact that we already have vision therapists who do that on an extremely high level every day, it's very, very easy for them to take a half an hour and work with each of our patients. And I love that part of our program, because I think it's a little bit unique. But I think it's much more effective than just me giving them a pamphlet on visual hygiene and sort of mentioning it. So I really do like that part of it.
I love that. Is a great practice management tip. I've never heard anyone have that as part of their program, but that's so like such a wonderful idea. And like you said, if you already have the vision therapy clinic, these are conversations that you've got staff members trained to have anyway. So just such a value added benefit.
Yep.
Well, but I know we're going a little bit long on our discussion, so I wanted to get one more piece of advice from you guys, since we have the luxury of having you on the show. We talked earlier about referrals, and I've also found in my own practice, a referred patient for myopia management is by far the easiest conversation that you're going to have, because parents have already kind of decided, like, this is the way I want to do things. I believe in this to help my child, and let's just learn about the options that are right for my own child now. So how do we go about garnering these referrals?
Do you want to go, Dr. Bonilla-Warford? Because I'm in a little bit of different
well, it certainly helps if you already have some kind of brand or reputation, kind of, as seeing children, in general. I don't know that it's absolutely mandatory, but I think it helps. It's really all about different types of building, relationships, and that can be really strong relationships. I mean, I have some excellent referral networks with other optometrists, where I will refer, out my scleral lens patients, because I am a big believer in scleral lenses, but I don't have enough time in my life to figure out the system and then train the staff to do that. Same thing with dry eye. I mean, dry eye is a huge problem, but we don't have a dry eye clinic here, and we, as eye care providers, we know so much about dry eye that we don't want to undertreat them by doing it the same way we did in the 90s. So I refer them lots of adults with lots of complex issues. They refer children with myopia and vision therapy. And so it's kind of like hitting them on all fronts, periodically sending letters that are genuinely educational, like, oh, there's this new research, or like, oh, this new thing. I mean, you better believe that when FDA approval, my site happened. I mean, we had letters, kind of ready to go to optometrists and, ophthalmologists and pediatricians, in our area, once we got, certified, which was right away. And so, so that's part of it. And then, also, I mean, you can't shirk, your website and your web presence, because if somebody does hear about you through word of mouth, I mean, they're gonna go to your website. And so it's helpful for us to have a page, like, in the news, like all of my like news appearances talking about different things. I mean, that's sort of, validating, and having lots of information. Back in the day, not so much anymore. We used to have a very, very active blog about children's vision. Now I spend, my time more doing like, TikTok and that sort of stuff. But I think just the consistency is really, really the key. There's different strategies. You can revisit it in different ways. But presenting yourself as like a, thoughtful, genuinely concerned expert, and, asking whoever you're talking to, how can I be helpful for you? What is it that you don't necessarily have the capacity to do at the degree that you would like to do in your practice, and, how can I help with that? And, I think that's sort of the core of all of the different outreach we do.
Yeah, I'm in a different kind of setting. So I have a smaller kind of pool where I'm getting referrals from largely our MD practice. And I think one of the reasons they're so open to myopia management has been because we've had the discussions with them from several years ago through now. So it's been a back and forth, just like you were saying, like discussion, and where we're sharing with them the newer updates, because it's just not on their radar. They have so many other things going on. Their specialty is surgery. So we're just kind of keeping them updated, so then they know when they have a patient who's a good candidate, what to do with them, and who's a good candidate, and who should they refer, and who is not a great candidate. So, the patient with sticklers, maybe not the best candidate to send over for myopia management. So just kind of educating them, and then they know what to do with the patient. So that's been largely our sort of outreach and referral system, is we're such a big practice. But doing some like community ed talks and things, and just letting people know that we have a myopia management clinic and that we're here has garnered some referrals from the community. But largely we're just kind of like an internal machine. So it's a little bit different than trying to do a ton of community outreach, but we do. And I think it comes down to communication with like my pediatricians internal to our practice in our hospital, and then also external. So I think pediatricians really appreciate getting that information. And like you were saying, in times of COVID, we can't like show up and do like a face-to-face kind of thing with them, but I try to give them a short, really concise little blurb in the note that goes back. Because I know from the pediatricians I've talked to, they're like, I don't want a 5-page thing I need to read. I just want to know, what are you doing? What's the option for that patient? And that's it. So I try to make it as easy as possible for them to follow along and know what we're doing. And then hopefully when they see kids with myopia, they can maybe even start that discussion themselves, and when they are headed over to us. So that's kind of where we stand with our referrals. And it's been getting real busy. So
awesome. Well, y'all, thank you so much for all of your insights this evening and all that you're doing to help just raise the bar and eye care to make this the normal way that we see and take care of our patients, because I think that's going to be a huge game changer as well, where if any parent takes their child to any eye doctor across the United States, they're all going to be offered this as a way to help prevent their prescription from worsening. So, I mean, I think that's the ultimate goal, is that we universally adopt this in, but we need leaders like yourselves to lead that charge and make it a primary part of their practice so that other people can follow in your footsteps. And thank you for sharing all of your tips this evening.
Thank you for having me on.
Yeah, that's great.
If anybody wants to kind of follow along with your practices or what you do you have a social media handle or anything that you would point them towards to be able to follow your path?
Well, we are Bright Eyes Tampa at most things. brighteyestampa.com, and Facebook and Twitter and TikTok, Instagram.
I don't really have any Facebook, Instagram, or TikTok. So you can just find me. Just search for my name. I can give my contact info if anybody needs it.
No worries. That's okay. You know what? It is such a time suck. Sometimes I wonder why I do it right now. Like,
I found myself getting into TikTok and wanted me to open the app, and I was like, "Oh no, I
back it up, delete."
I accidentally clicked on the TikTok. I need to get back off of it.
You know what? You look at this, the three of us. I don't think anyone would have guessed the one person who had TikTok would be Dr. Bonilla-Warford. The surprises keep giving.
Yeah. Well, another optometrist friend of mine, Carly Rose, she convinced me, you have to do it. You have to do it. And I did it, and it's been great.
You might finally sway me to download the app.
I know Dr. Rose first was talking about it like a year ago on our show. I was like, this is something I need to do. But then, life just keeps happening but I'm so glad really great people are doing it because y'all are doing it way better than I could. So
I don't know about that, but honestly, I know at some point we're going to end here, but that's one of my favorite things about TikTok is that even if I'm not educating, patients in my area, I can reinforce Carly's messages and I can reinforce other people's messages. And I think it goes a long way to, normalizing, these concepts. I mean, if I have a post on, myopia control on my site, and it, gets viewed, 30,000 times. And I have people in California and Chicago that are like, hey, where can I get that? Or, is this going to be good for my child? I mean, that's helping those doctors over there. And so I'm assuming that there are doctors, in other places that are doing this as well. And then that some of them live in my area. And so, I just really think it's good for, for us and for our patients all over.
Could not agree more. You're doing a major benefit to optometry and eye care as a whole by helping reach people where they're at. And this is where they're going to be open and learning about things that they never would have thought to put into Google to learn more about. So, it's so important that doctors like yourself are out there sharing this in a new way.
Yep.
Well, thank you again for your time. And we'll be back with the new episode. Make sure to follow us at Defocus Media, and we'll be continuing to share these conversations there. Y'all have a great rest of your night, and thanks as always for tuning in.
All right, colleagues, and it's a wrap. Thank you dearly for hanging out with the Defocus Media team. We hope truly something resonated with you. And if it did, be sure to give us 5 stars and make sure you follow us on all social media platforms: Facebook, Instagram, Twitter, LinkedIn, you named it. And our handle is at Defocus Media on all platforms. And until next time, be sure to keep it 2020, and we look forward to seeing you on the next episode.